podium.
That was good. Yeah.
I was gonna say pulpit.
The pulpit, yeah.
Be in church today.
Alright, so just put it back on for the video, endocrine system, as far as endocrine disorders, will be the first thing that we'll go over. The endocrine is obviously, like I said, we got glands, hormones, and receptors. I will make this visible to everybody too, send that out regarding everything. So, first thing, obviously, endocrine is very diverse. It's got a lot of different parts to it, so I just want to kind of make sure to kind of go over just a little bit of the breakdown a little bit. Obviously, the glands, we've got the pituitary, thyroid, parathyroid, adrenal, pancreas, thymus, pineal, and then of course the gonads, whether it be for male or female, your ovaries or your testes. So obviously, as it continues to go on regarding what your pituitary actually produces, your thyroid, I kind of broke those down. And of course is the parathyroid, your pancreas and your adrenal glands, your thymus, your pineal, and then your pancreas and gonads. So with calcitonin being one of them, who is,
It's on the other side.
was it on there?
No,
The
back,
back.
back twice.
I don't know.
Over there, the thyroid.
Okay, thyroid, okay, your calcitonin. So what is calcitonin? Can you tell me what it is? Because I'm building off of what you all know too. What does calcitonin actually do? So calcitonin, it basically helps maintain the blood calcium level, basically inhibiting the release of calcium from the bone itself. So kind of remembering what those are. And then what is the PTH as far as the parathyroid hormone? And what does it do? Integers. It helps regulate the blood's calcium balance. So kind of basically throws in the parathyroid hormone will actually stimulate therefore basically for the gland or the thyroid to actually produce the calcitonin in order to release the calcium. Now the calcium comes from which gland? What is the PTH? Just said it. Your parathyroids. Okay, so that's going to be your big part of that. And then dealing with your, because you got your parathyroid, your PTH, so your parathyroid glands, and then we get into your thymus. Anybody know what is so special or what is particular or different dealing with the thymus? It's different from when you are either a child to actually when you hit puberty. So basically the thymus, it is larger in children, and once you hit puberty, it actually decreases in size, and therefore, as they say, it will actually, they wonder once you're actually an adult, is actually, if it's even still there at that point. It kind of like atrophies and done. Okay? So a big thing to do with your thymus is your T cells. Anybody have any idea of what T cells are? So T cells are basically your immunity. Okay, this kind of builds up your immune system. It gives you basically all your required genes and basically your blueprint essentially from here moving on out. Okay. And then we got our hormones. We got our classified. Those are classified into 3 different types. You got your amines, polypeptides, and your steroids. Now your amines, basically this is from the tyrosine. Y'all remember hearing about that? That is basically it's an amino acid that's found in the proteins. Okay, that's and then you got your T3, your T4, also part of that group, and then you've also got your catecholamines. Now, I know that may sound like a little boring considering it's all breakdown of everything, but it's kind of it's a big thing. So dealing with your assessments, dealing with patients who are, your big things are like checking your nail beds, your cracking of your nails, your peeling of the skin, separation from the nail beds itself, and clubbing, facial expressions, eyeball protrusion. Anybody have an idea of what that actually is called? Because they will actually give you that name.
I remember we talked about it, but I don't remember the name of it.
Exophthalmosis. So you got like the protrusion of the eyes. So, symmetry of the trachea is going to be a big thing that you're going to take a look at whenever you're doing your physical assessment. You want to be able to tell, basically you go up, you feel around. If you got tracheal deviation, you may have either a goiter, you may have some other complications regarding the thyroid, or your parathyroid could be off as well, okay? Because your parathyroid, it does kind of wrap around, just like the trachea, the thyroid itself kind of wraps around the trachea, right there. So, and of course you look for any breast and nipple discharge, but just because of the gonads. So if your symmetry of your trachea is your thyroid, as well as your eyeball protrusion is your thyroid as well, dealing with exophthalmosis. So, diagnostic test, I just kind of broke it down just in general for each section, as you'll see today. Basically CT, MRI, X-rays, proactive testing, basically determine the endocrine glands, reserve the function to stimulate underactive gland to suppress the overactive gland. But, let's see, nope, nothing major on that one. So dealing with your treatments though, your non-surgical, there's diabetic meal planning, patient prep, and of course the radioactive iodine. And surgical, there is multiple of those, and we'll kind of go into those a little bit more detail, kind of give extra teaching points, things like what you're going to look for as far as your assessments, and what you'll, things just to kind of notice. So as you can see, common disorders basically on all. So dealing with your, the first one we said, let's go back to this though, where I hit it. So one thing dealing with the non-surgical treatment though for endocrine system, dealing with your radioactive iodine. With this one, you want to avoid, if you are pregnant and or your family or anybody of this particular patient is pregnant, you will want to avoid pregnant women and children within the first week after your last treatment of that. Okay, just because the exposure to radiation can obviously hurt the baby and the immune system and everything can lower down. So always make sure you're being aware of that as far as the family and or if it's obviously it's a female patient and or yourself. So surgical, dealing with the adrenalectomy is a big one. So due to treating the adrenal tumors, adrenalectomies, your corticosteroids are essential for life, basically. So with that, obviously that's where that's going to be produced. So must be replaced, so you're preventing adrenal crisis. Okay, I know you probably hear talk about that, but remember adrenal crisis, it is life-threatening, is a big thing with that. And does anybody know why? So with adrenal crisis, that's an emergency just due to hemorrhage. Okay, so when you have the patient who has had adrenalectomy, or basically if you're having a hemorrhage or a blood loss, what are some signs and symptoms of something that you may see with that?
Tachycardia.
Okay, so you got tachycardia, low blood pressure, usually you don't have enough volume basically in your pipes. And then of course dealing with your adrenal glands, where are those at?
Above your kidneys.
Okay, so dealing with, if we're having to go in to take those out, what are some things that you're expected to actually see on a patient with that? So all just in the abdomen, so any severe abdominal pain, any redness or drainage or anything like that. So around those particular incision sites, obviously infection. So, and then obviously a change in LOC. So if they're ultramental status, then that's going to be a lot of the stuff. Usually in regular adults, we may spike a fever and everything as well. That's kind of normal for our bodies to do initially, but if you're older, obviously, remember your altered mental status or your change in LOC is going to be your big thing. It's going to be your first indicator of a sign of infection. So always kind of keep that in the back of your mind as well. Now your big symptom that will be slightly different with this, does anybody have an idea?
If you have an adrenalectomy, I want to say something about if they produce corticosteroids.
Okay. So usually what steroids, what's it do to you? Make you jittery usually. So if you have that ataxia with the uncontrolled shaking, that's gonna be your big indicator that you're actually going into that adrenal crisis and you're starting to have some issues after you've had your adrenalectomy. So, also, Dylan wants now from there on, we'll hop on down to the hypophyseectomy, basically, or the removal of the hypothalamus and or the thyroidectomy. But a big thing dealing with the thyroidectomy, what is one thing that you as a nurse want to keep at the bedside? Because sometimes I know this has been questions and stuff as well.
Something involving their airway.
Okay. So you want to keep an ET tube, and you want to keep a trach care, not trach, trach kit, like if you have to initially put in a trach, okay? So just maintain the trach tray and bedside for 24 hours, just because of possible tracheotomy after a thyroidectomy, okay? Always assess for laryngeal nerve damage, and anybody have an idea of how you may assess that after a thyroidectomy?
Swallow.
Okay, you got swallow, and what else? There's one other. Verbally talking to them, essentially. Once they come out of anesthesia from the actual procedure, you want to see how they actually talk to you. Maybe a little, dry mouth, obviously, that's gonna be normal, but as far as the actual speech itself, that's gonna be very altered. So basically assess them for their speech alone after the anesthesia has wore off. That's gonna be able to tell you if you've got some laryngeal nerve damage from the actual procedure, okay?
Like hoarseness or worse than that?
Be worse than hoarseness, like they won't be able to get their nerves, like their words and everything formed at all. So it'll almost look and sound like word scramble, but they're not able to get the words out either. So, or expressive aphasia. Also, whenever you have a thyroidectomy, when you're actually going in at a bedside, what are some things, how are you going to determine if you're having any drainage or bleeding? What's some things that you're going to watch out for? Behind the neck.
Yeah.
Yep. Behind the neck is a big thing. A lot of people don't actually remember that. They will actually forget it, because when you first go in, and of course any incision, you're going to be, obviously you've got it across your neck, right? So you're having that removed. So you've got your dressing. Sometimes that dressing itself can be clean, dry, and intact. Because obviously with gravity, as you're laying in the bed, all of that is going backwards. So always assess at the back of the neck and kind of reach behind, just kind of feel and look for any type of bleeding or drainage on a pillowcase, or you may see it actually on your hand. So that's always a good thing to always make sure you're looking for. Also, since you are dealing with a thyroid, you've got your parathyroid there, right? So when you have that removed, you have a potential of causing damage to the parathyroid. So dealing with your calcium. Now, what are some signs and symptoms of hypocalcemia?
Like twitches in your muscles.
Yeah, twitches. A lot of numbness is a big thing, so you always want to look for, assess for any numbness. Any seizures is another thing you want to assess for, and of course your confusion. And that would basically let you know that you've had some damage to the parathyroid as well. And then there's some other things that need to happen after that. So now a big thing after the hypophyseectomy, I don't know if I'm saying that correctly or not, is basically your removing of the hypothalamus. What would you think would be one thing that you'd want to actually assess, or actually does anyone know how they actually do that?
They go through your nostril into your socks.
Exactly. So they go in through the nares. So in doing so, you're at risk of hitting a lot of nerves and a lot of issues dealing with your optic nerves and your vision. So when those particular patients, they come out of surgery, when they are actually awake, they're alert, they're actually can be able to somewhat see you, you want to do a vision test as soon as possible. Okay, so that's going to be a big thing. That way you can kind of see if it's any nerve damage, and then you'll continue to test that over time as well. That way you can kind of make your base assessment off of that. So, patient priority needs with those, let's see. Basically, monitoring weight is a big thing as well. Just dealing with Cushing's syndrome and diabetes, and adequate sleep is a big thing as well. Just making sure too that if they don't get enough sleep, basically it is a sign of hyperthyroidism. So we've caused it to go a little bit different. And of course, electrolyte imbalances due to hormone imbalances is a big thing as well, that you want to kind of watch out for. And then we get into Addison's. You may remember what Addison's disease is.
And they're really dry.
We need to add some hormones.
Yeah.
Okay. So it's low. Where is what organ is it? What organ are we affecting?
Thyroid.
It's got the same initial as the organ, the first one. Adrenals, yeah. So it's a low adrenal function. Now, what is one of your big key indicators, or if y'all remember, dealing with Addison's disease?
These people.
What is it with the skin?
It's like that bronze
Yeah.
color of the skin.
Yeah, you got that bronze discoloration, and then where else? Not just at the skin, you got it at the elbows. You got it like if your joints, basically dealing with your hands is going to be a big thing. So you got that bronze discoloration. So some lab work and everything with Addison's, dealing with where it's at. Some big things that you want to watch out for are what? Since we're dealing with the adrenal glands, which is on top of the kidneys, because if we're having that out, if we're not producing enough, your kidneys could also be affected, right? So you're watching your kidney function. So you're watching your BUN, you're watching your creatinine, you're watching your potassium. And also with Addison's, you will see an elevated potassium because your body's not able to properly excrete it all, as well as your sodium and your BUN will be elevated, okay? And then of course, you'll notice a decreased amount of, or your plasma is gonna be a big thing. Patient teaching with Addison's, your big thing with it is basically, it is, unfortunately from here on out, you are gonna be on a lifelong corticosteroids, okay? So, unfortunately. You're always roiding out. And then Cushing's syndrome.
Buffalo hump.
Okay.
Trumbull obesity, moon phase.
Okay. So it is a high adrenal function. Okay. So you're overproducing of this. So like you said, it's the buffalo hump, and you've got your moon phase. So that is actually your key indicators that kind of sets it across differently on the away from everything else. So now, what is to confirm a diagnosis besides the buffalo hump or the moon phase, what would you all think would be a good key indicator as far as to get your confirmed diagnosis with those patients?
Isn't there some special test with blood where you test the hormones and then at the beginning of the night or right before they sleep or something like that?
It's
Yeah,
the
you
blood,
get
is
that.
it blood ACTH level?
It's actually, and it's a decreased dexamethasone suppression test is going to be your big thing with that. And of course, also your elevated 24-hour urine cortisol and elevated nighttime cortisol levels. So that's going to be your big things. So if we're looking at moon phase, we're dealing with Cushing's, we've got an overproduction. So what are some things that we would do as nurses or to know that with these patients that what we're gonna do? What's some like some nursing interventions and or stuff that we're gonna do with them?
Monitor like output
Okay.
and
Are
weights.
you going to just, would you want to you probably want to put them on like a fluid restriction usually. You want to decrease the sodium, okay? Because they're already retaining a lot of, your cortisol and everything's already elevated. So you're already retaining a lot more fluid, so this is what gives you that moon phase. Well, you want to decrease their sodium or restrict the sodium and do a fluid restriction, so with those. And then, of course, you want to decrease the consumption of gastric irritating foods just because of the medications. It's going to cause some contraindications with that. And when they go home, because of the cortisol, they're going to have to be taking some IM injections. So you're gonna be doing a lot of patient education and teaching on the patient to actually how to give their own IMs and that stuff at home. So what muscle, if they're having to give it to themselves, what muscle would you recommend?
Outside of the thumb.
Okay. Yep. Which is called what?
I don't remember what it is.
That's just not our You're good. I just throw in extra stuff, why not? And then we've got diabetes insipidus, and then diabetes mellitus is a big thing. So now with diabetes insipidus, what are your cardinal signs essentially of diabetes insipidus? You may remember polyuria,
Pretty breath.
polydipsia, nocturia,
This is the 3 Ps one, what, polyuria, polydipsia, and there's one more. Not that one.
no for that one. Your cardinal signs with that is polyuria, polydipsia, nocturia, weight loss. And what would be your urine osmolality? It's gonna be a big thing as far as looking off of that. With that, you want a urine osmolality of less than 300 and a gravity of less than 1.005 is the actual number for that one. So, of course, teaching with diabetes insipidus, it is sodium restriction, same thing, if they're taking a thiazide diuretic, okay? And of course, just make sure they teach to wear a medical alert bracelet or a necklace or something, that way they would just be easily and more identifiable. So diabetes mellitus, there's 2 different types, there's type 1 and type 2. Which one is medication controlled? That you can do,
One is insulin, right?
so your medication control, or like your required medication
Oh,
is type
right.
1, yes.
Yeah.
So now, when can you be diagnosed or usually noted that you can have type 1? Childhood or actually already
Yes,
any time
early
from there on
adulthood.
out. Yes. And type 2, obviously your lifestyle change, so you're exercising, your dietary modifications. What age would you see that with these particular patients?
Like 30s, 40s, a lot.
There's about 45 or higher. So, and of course by that time, sometimes they may need assistance with certain medications, but primarily type 2, they can get by with just dietary modifications, changing up their diet. But usually by that time they have a lot of cholesterol issues, so you can put on other statins and some other medications and hopefully get those numbers down. And then of course you can hopefully, get that corrected as far as your A1C and stuff. And then you got hyperparathyroidism. So dealing with hyperparathyroidism. So if it's hyper, which means your PTH would be what? Up. So you've got an increased parathyroid hormone, because it's basically saying, hey, produce, produce, produce. Well, if we're producing, what was the big vitamin or supplement that we normally can take over the counter that the parathyroids produce? What's the big thing? Calcium. So what's going to be with your calcium? It's going to be up, it's going to be down, it's going to be up. What about your phosphate?
Low.
It's going to be low. Yeah. And then of course you've got a increased bone reabsorption. It's going to be a big thing with hyperparathyroidism. Now, it's more in women than men on this one, as far as your hyperparathyroidism. So with hyperparathyroidism, you want to find the underlying cause. Just like when, I don't know if you have already talked about DIC, if you're not, you will. But DIC with this, you want to find the underlying cause. Once you find the cause for what's actually causing the hyperparathyroidism, you correct that, your hyperparathyroidism will actually correct itself, okay? Another thing is you increase the bone density. Now, a couple medications to do that. You'll notice that these patients are taking it. What would be something that you would notice? What medication? Yep, in order to increase the bone density. Y'all remember, I think her name, Sally Fields, is that her name? The flying nun? I'm just really old, okay. So basically, it was a commercial that, like Fosamax, Boniva, stuff like that. So those are gonna be your medications that you're gonna see, okay?
So in hyperparathyroidism, where your calcium's up
Yes.
and your phosphorus is low, you want to increase the bones.
Yes, because it's basically your bone density is low, so because all your calcium has been released out into your system, so your calcium level is going to be up. So you're going to have that reabsorption back into the actual bone itself. So in order to do that, you take the Fosamax and the Boniva basically to get it, target it, and sling it back in there.
So our calcium is in our bloodstream at that point?
Yes.
And not, okay.
Yeah. So with that, which means your bones are more fragile, so you're higher risk for like fractures and things like that. Okay.
So is that patient at risk for a seizure since
They can be, yeah.
Okay.
And that's going to be a big thing. Very good. As far as like if your levels shift too much too quickly, then you watch out for seizure activity. Is a big thing. So, very good. And if you're unable to achieve homeostasis, I guess you could say, with that, dealing with your calcium level, what would be the treatment? We've tried medication, we've tried other things as far as dietary modifications to try to get that bone reabsorption in the calcium, but your parathyroid is continue to stimulate, continue to go.
Take it out.
Take it out. Yep. Possible parathyroidectomy. Very good. So, obviously monitor your electrolytes, strain your urine. So, and then dealing with your hypoparathyroidism, obviously it's a decrease in your parathyroid hormone. So your, what would be some causes with that, potentially?
The muscle spasms.
Okay. And so your, could be also, after you take it out, because the hyperparathyroidism, you can sling your patient completely over into hypo now. Because obviously it's a removal of the injury or the actual gland itself. And no parathyroid, obviously, and could also be like an autoimmune disorder. Okay, so that could be one indicator. So if they have their parathyroid and it hasn't been removed, you can look to see if any potential damage. And if no, then you potentially look at an autoimmune disorder as far as the actual cause of that. So what are two signs that you will notice that you can check for a patient for hypocalcemia? What's that called?
I don't know.
I know it.
Exactly.
Exactly. And what's the other one?
For the church.
Just fix, yes. So, yes, your blood, you guys,
Sign to you and you're gonna figure it out.
I know what you're talking about. So,
That's done, and what's the second one?
it's the Trusu, I don't know if I'm saying them right. It's the Chusovec, as what I always say. It's the blood pressure where you put the blood pressure on, the blood pressure cuff on. Once you pump it up, the arm will come up. Makes me think of a goose. So, it comes straight up. So, and then of course you got your Trusus. That's basically testing that facial cranial nerve. So, a neuromuscular irritability and psychosis is going to be another big thing that you'll notice with the hypoparathyroidism. So your treatment with that, obviously we're going to give them calcium since we're depleted on that, but what else do you want to give with calcium in order to make sure that it absorbs? What is it?
Phosphate.
Okay, that's one of them.
Magnesium.
Magnesium. One more.
Vitamin D.
Vitamin D. Very good. Now, with these particular patients, they are at risk, as what you talking about a while ago, regarding seizures. So you've got the tetany, you've got the jerking. So sometimes there is a condition that you will actually see. I've never seen it, luckily. It's acute life-threatening tetany. Basically, it's basically convulsing constantly. You cannot get them to stop. So what do you think that the treatment for that would be? Because if you've got your hypoparathyroidism and your calcium levels are very low, obviously, and we're not producing enough. So in order to create or correct, that's what I'm actually trying to say, the hypoparathyroidism or this acute life-threatening tetany, what do you think it would be?
Is it the IV calcium and
Okay.
IV magnesium?
Okay, so you give those and you're still convulsing and you're still constantly like jerking and you're like, so you're at risk of one, wearing your heart out, two, wearing your lungs, and as far as just the diaphragm. So usually with those patients, when they're in that condition, they sedate them. They intubate, knock them completely down, and they give IV calcium until the levels come back up, that they're actually good enough so they can actually stop. So,
Is that a temporary?
yeah, just temporary. It's immediate IV administration of calcium and sedatives and anticonvulsants. So that's a big one until calcium levels increase. Now, if you've got chronic tetany, I mean, obviously it's not a life-threatening, and we've continued to have this, so obviously you want to give the calcium and the vitamin D as a supplementation. That's what you want to do to get those levels up. Also with those, if you have basically anytime that you have the parathyroid, if you have a parathyroidectomy, a thyroidectomy, a hypothalamusectomy, I can't say the word. So with those, all of those, you do want to keep the ET tube and the trach kit at the bedside, at least for the first 24 hours, just because you may end up having to do, obviously, a trach. Now, besides that, with hypoparathyroidism, if you have a parathyroidectomy, the calcium alone, when you're doing that, because where it's so low, you're at risk for what? Remember we were talking as far as, what's some things that you kind of watch out for here dealing with the trachea? And dealing with the laryngeal, what can happen?
Nerves damage.
Nerve, but what's the spasms? So if it constantly like spasms, obviously it's going to constrict. So you've got, keep that at bedside, possible laryngeal spasms because of the hypocalcemia. So if your calcium gets too low, you'll notice you could have the spasms and you have to put a trach in, just temporary. So hopefully magnesium can also correct the spasms, which is usually what it is. So by giving that magnesium, the phosphorus, the calcium, and all that, the spasms should stop. If not, then prepare for your advanced airway for a while. And then you got hypothyroidism. What's two things dealing with that sets hypothyroidism aside as far as the key indicators? It's usually what the little grannies are always complaining of, but it's not the thyroid, it's just they're 98 at that point, so.
Memory loss. Cold.
Cold. So they're intolerant to cold, and what else? Remember, basically hypothyroidism, I think of Eeyore. We need to put very slow. I don't wanna move, no gonna do it. So if you don't wanna do nothing, obviously, and you eat, you're gonna have weight gain, because you're not actually up for, walking, you're not up stimulating, getting everything else going. So you're gonna have weight gain. Now, treatment for hypothyroidism. What medication we put them on?
Hormone replacement.
What's it called? What medication is it?
Levo.
Huh?
Levo.
Levothyroxine. Synthroid. Give it in the morning on an empty stomach. At least 30 minutes to an hour before you give anything else. And of course, now is it lifelong or is it temporary? What is it?
Lifelong.
It's lifelong. And then we go right on over to our, it must be on the other side, hyperthyroidism. What would be the so hyperthyroidism, we're moving, I think of teeth. ticker, all the time. Or me when all my meds kick in. Ready to take the world on. So what's gonna be going on with your labs?
Elevated.
Okay, what labs were they again? What labs were produced by the thyroid? T3, T4. So you're gonna have those elevated. Big one, the big one is gonna be your T4 though, more than anything. So now with hyperthyroidism, we've already kind of talked about one thing that is actually a key indicator that you can actually see. Dealing with the eyes.
Temperature.
Yep. What else? What's the other big thing that you'll notice?
Goiter.
The goiter. Yep. So you've got your increased T4, your goiter, possible exophthalmosis, and then watch for thyroid storm. Okay? It's going to be a big thing. Now, one thing, so it's just some memory joggers that can help you. We've got our temperature intolerance, that's dealing with our hypothyroidism. Your trastuzumab and your trastuzumab, I'm saying them right, but you know what I'm talking about. Gooseneck and I feel like I'm making at you, so there's your cranial nerve. That's dealing with hypocalcemia, dealing with your hypothyroidism. So now your skull fracture, this is dealing with like your patient history when you're actually going into your assessment. So skull fracture, surgery, complications of surgery, brain infections such as meningitis and encephalitis may actually help identify more of that endocrine dysfunction than actually anything. So that's why it's so important to actually get a good patient detailed history on what's actually going on. Because that's why because sometimes, remember us talking about like building that bond between the patient, a lot of times they're not going to let you know a lot of their history or, hey, I had this accident. Building that with them, that stuff right there will slip out like before you even realize it. So building that connection and actually talking to them, they'll talk to you, they'll be more apt to trust you, and therefore, you can get more out of the patient. Decreased bone density will show up on an x-ray suspected for what?
Hyperparathyroidism.
There you go. And do y'all know what step in wide means? It's a good little acronym that you can remember. So it's going to help looking over into thyroid storm. It's got your sweating, tremor, enlarged thyroid, palpitations, nervousness, weight loss, intolerant to heat, diarrhea, exophthalmosis. Step wide. That's how you kind of key indicator I'm looking at when you're actually looking at a thyroid storm. Kind of those key indicators. Now, dealing with the E, if you was to have a patient with that, we said that was exophthalmosis. What is some things that you kind of want to be a little bit more mindful on with those patients that you want to watch out for as far as just like their physical assessment when you're actually just literally just physically looking at them and or doing in the room. It's not dealing with regarding the lab, just some extra care, some things that we as a nurse need to kind of be mindful of.
Lighting in the room.
Lighting.
Eye drops.
Very good. Eye drops. And so your artificial tears, because the protrusion all the time is going to be very dry. One other thing. I'm trying to give a hint. Pirate.
Eye patch.
Eye patch. I'm thinking like Captain Jack off the bottom of the boat. So
I just wanted to see how far it was gonna go.
I mean, I was starting to
Next
get.
thing you know, he's in for the room.
So, alright,
You
yeah, I
gotta
know.
do that.
But yeah, so your big thing is eye patch or sunglasses because of the lighting is gonna be a big thing, is that hurt them, and then of course your artificial tears. So basically moisturizing, and of course medications and or surgery.
Would it ever just be one eye and not both? Rarely?
Used very rarely, I've never seen it or known it's actually,
That's when you get the eye patch?
you kind of switch them back and forth.
Oh. You do the double whammy.
Yeah.
Okay.
So you go look in, and it's not Ray Charles in there, it's different reason for those sunglasses and that patch, yeah. So now dealing with your decreased bone density, like you said, that is your parathyroid disorder. So, and I got done 15 minutes before I was supposed to talk, I guess. So, dealing with that, T cells, like I said, that's gonna be for your immunity, so just kind of remember that. Your eye protrusion, exophthalmosis, dealing with your thyroid, and usually if you have a male patient and they come in and you notice that they are having some lactation. What is that a sign of?
Low hormone levels.
What is it?
Is it to deal with the hormone?
Yep. It's, is it gonna be up? Is it gonna be low?
It's gonna be low.
Higher. It's gonna be higher usually with that because of the, men, we don't lactate. So obviously we've got a hormone imbalance dealing from our gonads or testes for us. So dealing with that, usually it's prolactin. It's gonna be a big thing that you're gonna notice on those levels. Those levels will be more elevated. And you give them pads, just like the bro. Like here, let's cover them up. Let's
Is
pad
that
it up.
just your body's way of trying to get the hormones up?
Yeah, it's just, I mean, that's the body's, once that hormone is actually there, that's what it's doing. Like, we need to produce, we need to get this milk out. And so, some men, they actually, because they got on colostomy and because of that, that is actually gonna be something you will actually notice. So, if you see somebody walking around and they look like they got a huge areola, it's probably, they may have a pad that. So, I doubt it, the areola won't be that big, but, you know, let's kind of be mindful of that. So, just because of that prolactin. So, let's ask
Can
a
you
couple.
refresh us on a thyroid storm? What all it entails?
That's what the second one was.
Step one.
Okay.
That's your sweating, your tremor, your exophthalmosis. No, wait, no. Well, that's part of it.
You're sweating, yeah, your tremor and large thyroid.
Yeah, enlarged thyroid. Palpitations, nervousness, weight loss, intolerant to heat, diarrhea, and exophthalmosis.
What do we do?
Well, if you go in and you notice that they're sweating, and usually their heart rate and everything like that is up, so obviously you're kind of worked up. So your first thing, your treatment with that is just medications. Call the doctor because we need to get into surgery. So, and then
Also, you said earlier this, in the presentation, that if they have like a sunken trachea, or something like that, or like a goiter, you were kind of feeling around, but in class we kind of talked about if they have a goiter, you don't want to touch it because it could release those hormones.
yeah, if you have a goiter, if you're enlarged there, you don't want to palpate or actually push on that. However, if you're just looking and doing your actual assessment to feel for the thyroid and or the parathyroid, and you're looking and you're assessing the actual trachea for like any slight deviation, if there's no swelling there, yes, you can palpate, but you don't want to push too much even on those because you don't want to secrete anything. So, but yeah, if they have a goiter, then you can forget it because you already know.
Have you ever heard of like a goiter or any type of thyroid issue, like closing off the trachea?
It can shift it, when it's actually too much swelling, that's what will cause the actual, it can cause the laryngeal, spasms. And therefore, that's what will actually close off the airway, so that's why you have to keep the, trach kit and the ET tube at bedside. And then because of too much swelling, like I said, because not only the spasms, but the shifting of it as well can do a lot of stuff, so that's when you have to have that. So with that in turn, remember that you're giving your magnesium, you're giving your calcium, your replacement, your sedative, your anticonvulsives, because I mean, a lot of times you're gonna have a lot of stuff going on. And then just getting your airway and just having the doc and the tray readily available, so. Let's got some questions, so, alright. Endocrine function can be tested by direct, indirect, or proactive testing. An example of indirect testing would be what? Urinalysis to assess for ketones, fingerstick blood sample to assess blood glucose, calcium measurement to assess PTH, or D, stimulate the adrenal glands to assess cortisol activity. If you're
C
wanting
or
to,
D?
what is it?
C or D? One of
C
those.
is correct. Yep. You want to calcium measurement to assess the PTH. So your parathyroid hormone increases your calcium, obviously. Therefore, high calcium levels would be indirectly indicate high PTH. So urinalysis with ketones, fingerstick blood glucose are examples of direct testing. Stimulating the adrenals to test the cortisol, an example of a proactive testing more than anything. So very good. Number 2, your removal of the hypothalamus is a risky surgery that is used to treat pituitary tumors. Attentive nursing care before and after the procedure is intended to prevent and or manage which possible complication? A, headache from cerebrospinal fluid loss and transient diabetes insipidus. B, cardiomegaly and thyroid storm. C, tracheal collapse and cyst rupture. Or D, pain from the bone deterioration and elevated serum glucose. A, your headache and cerebrospinal fluid loss and diabetes insipidus. So now also, anytime that you have a skull fracture or you have a procedure dealing with the nasal passage and where you're actually going into the brain itself, if you go in and you assess your patient and you notice that you've got some nasal drainage, and of course it's right in the middle of all the allergies, so everybody thinks it's just their allergies are running. So what is a test that you can do to notice if it's blood actually dripping from their nose, if they have epistaxis and they have a history of it, but you want to make sure because their status post, their hypothalamus is being removed.
There's some like STAR test or something where you look at the drainage and see, and if it makes like a certain shape or something, you can tell if it's CS.
Halo sign.
Halo sign.
It's a halo. Very good. Yep, you get you some 4x4s, and you basically get the drainage and you put it on. You got your blood will stay compact, it'll stay on one side, and then you'll notice like a clear ring on the outside of that, and that's gonna be your cerebrospinal fluid. So that's how you know you've got a leak.
So then do you just like swab that and send it to the lab, or?
No, it's right there bedside. So that's all you're doing with
No,
that.
I know
It's
you
just-
do that, but
Oh.
after you see that you're leaking CSF,
Then if
you notify
it's
the provider and tell them.
provider, yeah, because
Okay.
you need to go back in for surgery, because you've got a leak and you can cause all kinds of issues and you're at risk for higher infection dealing with like meningitis and things. So, with that, cerebrospinal fluid, you can also test, for glucose. So yours, that particular fluid is gonna be a lot higher, so your glucose is gonna be very high with that. Okay. Number 3, a client newly diagnosed with Cushing's, which is what? What did we say that was? Get your moon face, buffalo hump.
yeah.
but that's
Truncal
what?
obesity.
What gland?
Adrenal.
Adrenal. High or low? High. Very good. So you've got a newly diagnosed Cushing's syndrome, received education about the condition. Which statement requires further teaching by the nurse? A, my condition is a result of an overactive adrenal gland. B, Cushing's syndrome can make me unintentionally lose weight. C, my moon face and ruddy complexion are most likely due to the Cushing's syndrome. Or D, I need to monitor my fluid intake and my weight as I will likely retain water.
B.
Cushing's syndrome causes unintentional weight gain rather than weight loss. Very good. And number 4, diabetes insipidus may be caused by which of the following? Select all that apply, so you're going to give me more than one, obviously, and I've got only 4 options. So we've got intracranial metastatic lesions, family history of diabetes insipidus, uncontrolled blood glucose, and head trauma.
B.
Diabetes could be caused by what?
B.
B is correct. Family history of diabetes. What else?
What were the last 2 options?
Besides that, we've got intracranial metastatic lesions, uncontrolled blood glucose, or head trauma.
It's not head trauma. I think
I would say C
I
too.
think it's C, the cranial lesions one.
Yep, intracranial metastatic lesions is another one. And your head trauma is actually one.
So it's all of them except for the blood glucose
It's
one.
uncontrolled blood glucose is the only thing that is not. It's actually going to be a cause, could cause diabetes insipidus. Oh, very
Because
good.
that's the result, right?
Yes. All right. Let me see. Get some more questions here. My complex prep too. Just gotta make brief since review. So with endocrine, what did she have on the list that she was wanting to?
She hasn't posted it yet.
Nothing.
I emailed her asking her.
We
she hasn't
just
posted
know
it
there's
yet.
7 questions coming from endocrine and diabetes altogether. There's 7.
I feel like you did a very good, put a very good dent in it though. I would be shocked if any of her questions were not something we've already been over.
And so I feel like she's gonna ask a lot of Cushing's,
Yeah.
Addison's,
And like education.
and like
stuff on that.
education stuff for that
Yes.
kind of stuff, and like the thyroid stuff, like kind of like that. I don't know.
So now dealing with your x-rays again, increased bone density in a patient with, x-rays reveal increased bone density in a patient with what?
Increased bone density.
Yes.
With hypothyroidism.
Very good.
Which one is it?
Hypoparathyroidism.
That's when you have way too much calcium
Yes.
inside.
And, okay.
Mhm.
Increased.
Diabetes is a big one, which I know that's a lot of dealing with like your buffalo hump is a sign of Cushing's syndrome. This looks like your big one. Let's see. No. Cushing's syndrome teaching tips is another one. I'm kind of looking at encourage patient to reduce the intake of gastric foods and substances such as coffee, NSAIDs, or alcohol. High levels of cortisol can inhibit gastric mucosal secretion and make the stomach at a higher risk for irritation and bleeding. So, advise the patient to take replacement steroids with antacids or meals to minimize the irritation. Instruct the patient with IM use of cortisol when ill and unable to keep food down to provide guidelines when the patient should, and then also when they should contact their doctor. If you are, what are some signs that your patient with Cushing's is not getting enough steroids, if we're looking at an underdose of steroids? Since we have to give them.
They're just gonna maintain their symptoms.
which is what?
That's Buffalo. And,
Well, the weight gain is actually an overdose if you, as far as your steroids. So if you're continuing to gain weight, you're giving too much steroids. So as far as your supplementation, because once you figure out that you've got Cushing's and you begin your treatment, which is the cortisol, and so when you're actually looking at dosing to get that good parameter for your patient, if you're continuing to have weight gain after you do your dosage of your steroids, you're overdosing. So some even more edema besides the moon face and everything. You'll notice a lot more, I guess it would be anasarca as the other. Their output would probably go down. So, because obviously they're retaining more of that.
so you're asking if we give steroids and it's not enough?
Yeah, and basically what would be some signs of the
Okay.
underdose. So then you would basically, fatigue, weakness, and dizziness could be one thing that it could be causing, but if we're continuing to do what we're treating it for, then we're overdosing it. So, then you have to just kind of taper from there, so.
Can you go over DKA versus, H? Yeah.
What?
Doesn't have,
HHS.
yeah.
So DKA,
Ketones.
yes, so basically with your DKA, your big one though, as far as if you're determining if it is DKA or if it's not, the big thing is looking at your anon gap when you're actually looking at your blood work. You wanna see if what they say is like open. So dealing with the anon gap, usually normal level on that, it depends on facility, you're looking at maybe like, let's say, I think the last one was here, like 10 to 15, I think. Obviously, if it's higher, if it's elevated out of range, then obviously it's open, and we're of course DKA, putting off those ketones.
And our blood glucose on DKA is gonna be
Your glucose and everything is going to be all up.
300 to 600. And then the other,
950 or
Okay.
1150 is what I was thinking.
okay,
Yeah.
so just up.
Yeah, yes. So now, also, once you're with DKA, what is some things that you're expected for a patient to be as far as the treatment? Obviously, you're gonna be,
Insulin drip.
Very
Potassium.
that's gonna be a big thing, cause you're basically, you're gonna be shocking your potassium and your electrolytes back into the cell with all that extra insulin. So when you do that, and of course you're given diuretics and other medication to excrete it, so, pay attention to your electrolytes. Your potassium is gonna be a big one, okay? So you've got your insulin drip and you're checking that every hour. You do a blood sugar every hour and you're doing your blood work and everything. So once your blood sugar, you can still be in DKA if your blood sugar is within normal limits and your anon gap hasn't closed. So if you work in ICU and you've noticed, or certain cardiac units, that if you've got an insulin drip for DKA and your blood sugar is like 120, you know, it's like, why are we continuing to do this? Look at the anon gap, because your anon gap could still be out of range. And usually, if they do have that, you will also see D5 half normal saline or something like that also infusing, just to make sure that you don't tank their blood sugar at the same time, okay? So it's that balancing act with that, just until you get that gap closed on their labs, and then you can actually, then it switches over just to a hyperglycemia, and then you can actually take them off and put them on a sliding scale, or glucomander is actually what they do here too.
So when we come off of insulin, we're going to,
If you're coming, once you're coming off the drip, you'll either go onto either sub-Q or like a glucomander, as far as that way they can kind of dose it. Then from there, they'll play with your long-acting insulin and your short-acting insulin. So you're dealing with like your Levemir, your Lantus, those long-acting insulins, obviously your peak times is going to be a big thing. So you're looking at like your 10 to 12 hours as far as your peak times on those. Sometimes that's why you'll see those patients, they'll be on Lantus 35 units twice a day, in order just to kind of, by the time it peaks and everything, is in order to maintain their sugars even throughout basically a 24-hour period. And then, or they may play with their sliding scale. They notice that it's just more up during the day, obviously with meals and with everything. So of course, then they'll just play with their sliding scale, and then they'll keep them on a long-acting insulin at night to make sure to see what their blood sugar is in the morning. So once you come off the drip, you should come off with your D5 and everything as well. Because I mean, obviously, if you're coming off the drip, then the whole reason why you were on the D5 and hypernormal saline is basically to help maintain your blood sugar so it doesn't tank you out. Well, then if you do that, you're going back into hyperglycemia and then rubbing it all over again. So just make sure that you're taking that off as well. But if you notice you come in, they DC the drip and you've still got the D5 going. I mean, obviously, as a nurse, question it, hey, you still want this? I just want to make sure their sugar is this. You want to switch them over to the hypernormal saline as far as fluids. But if they're drinking, fine. Usually with diabetes, you've got all your polys anyway. It shouldn't be an issue with drinking and hydration. So it's just kind of watching electrolytes is a big thing with that. So that'll come off. Then you go over to your sliding scale.